Imagine treating a broken arm by just putting a cast on the patient's legs simply because that's what the broad epidemiology statistics suggested you do. I mean, it sounds completely absurd.
Oh, totally. Yeah, it sounds like malpractice today.
Exactly. But when you look closely at the history of gynecologic oncology, the standard treatment approach for decades was, well, it was almost that imprecise. It was a blunt, sort of one-size-fits-all sledgehammer.
Right, because you had morphological classification, meaning just what the cells literally look like under a microscope.
Mm.
And based on that, almost everyone got the exact same thing. Primary debulking surgery, followed by standard platinum taxane chemotherapy.
Right. Which means we were essentially fighting a highly sophisticated, mutating enemy completely in the dark. We categorized these diseases by anatomical location, so ovary, uterus, cervix, and applied the same generic protocols across the board.
Yeah, but we are currently living through this massive paradigm shift. We are, finally turning the lights on. The field is transitioning so rapidly into this era of precision medicine, guided by comprehensive genomic and molecular profiling. We're actually treating the specific biological circuitry of the individual tumor now.
Which brings us to the core mission of our deep dive today. We're tailoring this analysis specifically for you, whether you're a medical student prepping for boards, a young oncology professional, or just a self-taught learner trying to grasp the absolute cutting edge of medicine.
And we are extracting the most crucial, actionable insights from a really definitive source text in the field Masaki Mandai's Personalization in Gynecologic Oncology. We're going to unpack the molecular targets, the pivotal trials, and the customized care strategies that are, frankly, transforming this whole landscape.
By the time we finish this deep dive, you'll understand not just what therapies are being used, but the underlying mechanisms of how and why they actually work at a cellular level. And to make sure this info really sticks, we have a specific clinical review scenario waiting for you at the very end.
So let's start with ovarian cancer. It's a disease notoriously diagnosed at advanced stages because, well, its early symptoms are just so vague. Historically, survival rates were really grim.
But precision medicine has opened up two massive attack vectors, targeting critical survival mechanisms of the tumor. And the first one is its blood supply. I mean, a growing tumor is hungry, right? It needs a vascular network.
Right, it needs to feed. A tumor literally cannot grow beyond a couple of millimeters without establishing its own blood supply. It secretes this protein called vascular endothelial growth factor A, or VEGFA.
Okay, so VEGFA.
Yeah, think of it as a chemical distress signal telling the body's blood vessels to grow directly toward the tumor. So we developed angiogenesis inhibitors, specifically bevacizumab.
Or BEV, as it's usually called. It's a recombinant humanized monoclonal antibody. So it basically circulates in the bloodstream, intercepts that VEGFA signal, and just binds to it.
Exactly. It neutralizes the signal before it can reach the receptors on the blood vessels. So the blood vessels regress, and the tumor starves. It's brilliant.
And the trial data for this is pretty extensive, isn't it? The frontline phase 3 trials, GOG-0218 and ICON-7 tested adding BEV to standard chemo. And both showed significant increases in progression-free survival.
Right, they did. We saw an increase of about 3.8 months in GOG-0218 and 1.5 months in ICON-7. And then in the recurrent setting, trials like OCEANS and GOG-0213 showed a real benefit for platinum-sensitive patients.
Oh, and don't forget the Aurelia trial. That one showed a massive jump for platinum-resistant patients, moving progression-free survival from 3.4 to 6.7 months. That's almost double.
It is. But we have to look at the mechanism here, because if a tumor is a living, adapting organism and you block its main road for blood supply, doesn't it just, build a detour?
Oh, that's a great pushback. Like, is bevacizumab actually killing the tumor or just forcing it to find another blood supply?
That is the exact biological hurdle driving current research right now. The tumor absolutely builds detours. It activates alternate signaling pathways, things like fibroblast growth factor or platelet-derived growth factor.
Wow, so it just reroutes the plumbing.
Yeah, pretty much.
Yeah.
And hypoxia, the lack of oxygen caused by the drug, can actually trigger the tumor to become even more aggressive or mutate further. This whole phenomenon of tumor heterogeneity and adaptive resistance is why BEV isn't a universal cure.
Which means the search for predictive biomarkers is absolutely vital. We have to identify whose tumor is uniquely dependent on the VEGF pathway before we administer the drug.
Exactly. And researchers are finding those clues across multiple modalities. They're not just looking at the tumor tissue anymore. They're looking at serum, at imaging. Like in GOG-0218, high microvessel density measured by a protein marker called CD31 correlated with way better outcomes.
And serum markers like the cytokine IL-6 have shown predictive value, right? Plus, in ICON 7, they found this complex combo of mesothelin, FLT4, and AGP combined with CA125 could really pinpoint responders.
Yeah. But honestly, the imaging biomarkers are the most fascinating to me because they're totally non-invasive. A routine CT scan can actually offer predictive value.
Wait, really? Just a standard
Oh,
scan?
yeah. For example, the presence of a site that abnormal accumulation of fluid in the abdomen is highly predictive of BEV efficacy, which makes biological sense because VEGF is incredibly potent at increasing vascular permeability.
Oh, so that's what causes the fluid to leak into the abdomen in the first place. That
Makes
makes total sense.
Right. And even high visceral fat density on a scan has been linked to prolonged overall survival with bevacizumab. It just goes to show how the patient's systemic metabolic state really interacts with the drug.
Okay, so if starving the tumor is vector 1, the second attack vector is destroying its ability to repair its own DNA. We are talking about PRP inhibitors?
Yes, the biology here is so elegant.
It really is. Imagine a cell's DNA repair system is a critical hospital building, right? And it has two main backup generators. If a patient has a BRCA mutation, that genetic defect inherently takes out generator A.
The cancer cell is highly vulnerable at that point, but still surviving. It's just limping along on generator B.
Exactly. So the PRP inhibitor is a targeted drug that specifically knocks out generator B. Suddenly you have a total hospital blackout, and the cancer cell dies, while the healthy cells, which still have generator A intact, survive. This is synthetic lethality.
Synthetic lethality completely changed the trajectory of ovarian cancer treatment. PARP, or PALT-ADP ribose polymerase, is an enzyme that detects and repairs single-strand breaks in DNA.
And when the drug inhibits PRP, those single-strand breaks deteriorate into double-strand breaks during cell replication, right?
Exactly. A normal cell uses a highly accurate process called homologous recombination to fix those double-strand breaks. But a cancer cell with homologous recombination deficiency, or HRD, which includes those BRCA1 and BRCA2 mutations, well, it lacks that ability.
So the DNA damage just accumulates catastrophically.
Yes, and that triggers cell death. The clinical validation of this has been staggering. We have 4 major frontline trials: PIOLA-1, PRIMA, VELIA, and the absolute standout, SOLO-1.
Let's talk about SOLO-1, because that focused specifically on patients with advanced ovarian cancer and a germline BRCA mutation. After 5 years of follow-up, using the PIRP inhibitor olaparib as maintenance therapy resulted in a hazard ratio of 0.33 for progression-free survival.
Which is wild. A hazard ratio of 0.33 translates to a 67% reduction in the risk of disease progression or death. In advanced oncology, seeing survival curves separate that dramatically, it's incredibly rare.
It essentially solidified maintenance PRP inhibition as a mandatory standard of care for these profiles. But what about patients who eventually develop resistance?
That's where the field is deploying antibody-drug conjugates, or ADCs. Instead of the old smart bomb metaphor, think of an ADC as a molecular Trojan horse.
Oh, like mirvetuximab soravtansine.
Yes, great example. It features this innocuous-looking antibody that specifically seeks out the folate receptor alpha. That's a protein heavily expressed on the surface of a lot of ovarian cancer cells.
So the cancer cell binds to the antibody and willingly swallows it inside.
Exactly. It invites it in. And once it's safely past the cell membrane, the linker molecule dissolves, releasing a highly toxic microtubule inhibitor poison directly into the cell's cytoplasm. It destroys it from the inside out.
That is amazing. It bypasses so many of the resistance mechanisms tumors develop against traditional chemo. We're delivering the payload exclusively to the cells that express the specific receptor, totally sparing the surrounding healthy tissue.
Right. But what happens when the tumor eventually mutates to survive both angiogenesis inhibitors and PRP inhibitors?
That's the terrifying part. It forces us to look outside the tumor itself and actually turn to the patient's own immune system. Which brings us to the PD-1 and PD-L1 pathway.
Cancer cells are insidious in how they evade detection. T cells, which is the soldiers of the immune system, constantly patrol the body. They possess a receptor called PD-1.
And healthy cells express a complementary protein called PD-L1.
Right. So when a T cell approaches and the PD-1 receptor meets PD-L1, it acts as a molecular handshake. It's a biological do-not-kill-me signal that induces immune tolerance.
But cancer cells exploit this, right?
Yeah.
They express massive amounts of PD-L1. They essentially drape themselves in a molecular invisibility cloak.
Exactly. So immune checkpoint inhibitors, drugs like pembrolizumab, dostarlimab, durvalumab, they're designed to block this handshake. They rip off the invisibility cloak, reactivating the T cells to recognize and attack the malignant tissue.
And when we look at how this applies across different gynecologic cancers, endometrial cancer really stands out as the prime target for this therapy. But why is that exactly?
It comes down to its unique genomic instability. Endometrial cancer has the highest frequency of mismatch repair deficiency, or MMR, and microsatellite instability high, or MSI high, status among all gynecologic malignancies.
Roughly 17% of cases fall into this category, I believe.
Correct. Because their inherent DNA repair machinery is so deeply flawed, these tumors accumulate thousands of mutations. This chaotic replication creates a massive amount of mutated abnormal proteins called neoantigens.
Which basically makes the tumor look extremely foreign, loud, and alarming to the immune system, like it's flashing neon signs saying, I am broken.
Yes, the immune system is already primed to attack. It's just being actively suppressed by that PD-L1 invisibility cloak. So when you administer an immune checkpoint inhibitor, you basically release the brakes.
And the Keynote-058 study demonstrated this beautifully. It showed an incredible 57% objective response rate for pembrolizumab in MSI-high endometrial cancer.
It was a huge breakthrough, but it leaves a really big question. What about the other 83% of endometrial cancer patients? The ones whose tumors are microsatellite stable, or MSS?
Right, because they don't have that high neoantigen load to alert the immune system in the first place.
Exactly. For the MSS population, single-agent immunotherapy kind of falls flat. However, the Keynote 146 and Keynote 775 trials prove that combination therapy can overcome this.
By combining pembrolizumab with a multi-kinase inhibitor called lenvatinib, right?
Right. They altered the tumor microenvironment, making it more hospitable to T-cell infiltration. This combo proved highly effective, showing significant survival benefits regardless of the patient's mismatch repair status.
Okay, so if endometrial cancer responds because of a high mutational load from faulty DNA repair, where does that leave cervical cancer? Because cervical cancer is primarily driven by a virus, the human papillomavirus, not necessarily a spontaneous DNA mutation.
Well, cervical cancer's relationship with the immune system is distinct. It's driven by persistent infection with high-risk HPV, predominantly types 16 and 18. These viruses integrate into the host DNA and constantly express viral oncogenes known as E6 and E7.
And those disable the cell's natural tumor suppressor proteins, P53 and RB, effectively immortalizing the cell.
Yes. But interestingly, genomic studies reveal that PD-L1 gene amplification frequently occurs in cervical cancer. The tumor genetically wires itself to overexpress that immune-suppressing signal.
Oh, wow. So that makes it highly susceptible to checkpoint inhibitors, too.
It does. Plus, because we know the specific viral targets, the E6 and E7 proteins, researchers are actively developing therapeutic vaccines. Not the preventative ones given to teenagers, but vaccines designed to induce robust mucosal cellular immunity to actively seek out and destroy existing lesions.
That is an incredible avenue of research. But I want to ask about something much rarer mentioned in the text, gestational trophoblastic neoplasia, or GTN.
Ah, yes.
It's this bizarre spectrum of pregnancy-related diseases ranging from hydatidiform moles to choriocarcinoma. Usually it's highly sensitive to chemo, with cure rates near 100%. But what happens to the roughly 10% of patients who are chemo-resistant?
Historically, a chemo-resistant GTN diagnosis was devastating. Very few salvage options. But think about it, GTN originates from placental tissue, and the placenta naturally expresses high levels of PD-L1 to prevent the mother's immune system from rejecting the fetus.
Oh, of course. So the tumors retain that PD-L1 expression.
Exactly. So treating these highly resistant, relapsed GTN patients with immune checkpoint inhibitors like pembrolizumab has yielded dramatic curative responses. It's providing a vital lifeline where none existed before.
But to deploy all these immunotherapies effectively, we have to identify the right patients. Which brings us to the complexities of emerging biomarkers. We understand MSI-high, but the text delves into tumor mutational burden, or TMB.
Right. TMB measures the sheer number of mutations inside a tumor. The FDA actually approved pembrolizumab for any solid tumor that is TMB high, which is defined as having more than 10 mutations per megabase of DNA.
But there is a massive caveat here, isn't there? TMB high strongly predicts a response in endometrial cancer, but interestingly, it fails as a reliable predictor in cervical or ovarian cancer.
It really highlights a critical lesson in precision medicine. You cannot assume a biomarker's behavior is universal across all tissue types. The biological context of the organ matters immensely.
And then there's the genomic instability score, or GIS. This isn't just looking for a single mutated gene like BRCA. This sounds infinitely more complicated.
It is. GIS represents a monumental leap in diagnostic technology. It's a highly sophisticated algorithmic score that quantifies the total structural chaos in the tumor's genome. It calculates three distinct variables.
Okay, what are they?
First, loss of heterozygosity, which basically means the cell has lost its backup copy of a gene. Second, telomeric allelic imbalance. That occurs when the protective caps at the ends of the chromosomes are fraying and uneven.
And the third?
Large-scale state transitions. This is where massive chunks of DNA break off and reattach in entirely the wrong places. GIS takes all this structural damage and outputs a score indicating how broken the DNA repair machinery truly is.
The clinical application of quantifying that chaos is stunning. The Mediola trial utilized a triplet therapy approach combining the PRV inhibitor olaparib, the immunotherapy durvalumab, and the angiogenesis inhibitor bevacizumab.
And the results were incredible.
Yeah. In a small subgroup of 10 patients who tested GIS positive, the objective response rate was 100%. Every single patient responded. Even in a small sample size, seeing a 100% response rate in recurrent platinum-sensitive ovarian cancer is just a massive signal of biological activity.
When you combine precise biomarkers with rational multi-targeted therapies, you can achieve unprecedented outcomes. But, and I'm sure you're thinking this, it introduces a massive logistical problem.
Yeah, exactly. We now have tumors categorized by dozens of different molecular signatures.
Right.
We've completely rewritten how we define these diseases, like uterine sarcomas. We used to classify them just by their tissue morphology.
Right. And now, leiomyosarcomas are defined by frequent TP53 and RB1 mutations. Low-grade endometrial stromal sarcomas, or ESS, are defined by a gene fusion called JAZF1SUZ12.
Gene fusions are wild.
Think of a gene fusion like two separate pages of an instruction manual accidentally getting torn out and glued together.
Yeah.
Suddenly, the cellular machinery is reading a bizarre, corrupted sentence that tells it to multiply out of control.
And high-grade ESS is driven by completely different fusions, like YWHAE NUTSHU M2AB, and PCOMAs are driven by mutations in TSC1 and TSC2, which hyperactivate the mTOR pathway.
Endometrial cancer underwent the exact same revolution. It's no longer just the simplistic type 1 estrogen-driven or type 2 aggressive models. The Cancer Genome Atlas completely reclassified it into 4 distinct genomic categories.
Right. 1, the Powell category, which is ultra-mutated because the proofreading gene is broken.
Yeah.
2, the MSI category, which is hypermutated. 3, the copy number low group, representing classic endometrioid tumors. And 4, the copy number high group, which behave aggressively like serous ovarian cancers.
But here's the major logistical pushback you mentioned. Running traditional clinical trials for all these microscopic, hyperspecific genomic subgroups seems functionally impossible.
You're slicing the patient population pie into thinner and thinner pieces. How can the medical infrastructure possibly recruit enough patients to test drugs for a subgroup that might only represent 2% of the population?
It can't. The traditional trial architecture was just too slow and rigid. So this necessity birthed the concept of master protocols. Instead of starting a new, standalone trial for every single drug and mutation, a master protocol establishes one overarching infrastructure to test multiple hypotheses at once.
Oh, this is where you see terms like umbrella, basket, and platform trials.
Exactly. For example, the AMBITION trial is an umbrella study for recurrent ovarian cancer. Under one protocol, it tests patients for HRD and PD-L1 and then sorts them into specific treatment arms based on their unique molecular profile.
And conversely, there's the KEY trial, right? A biomarker-driven platform trial.
Right. A patient's tumor is sequenced, and depending on whether they harbor a PIK3CA, BIF, or ERBB2 mutation, they're dynamically slotted to a specific targeted therapy arm. It's vastly more efficient.
Saving literally years of administrative setup time. So we have precision trials matching precision diagnostics. But true personalization goes far beyond sequencing the genome of the tumor. You have to treat the human being hosting the tumor.
Yes. This means integrating patient-specific demographics, specifically their inherited genetics and their biological age. Regarding hereditary risk, the textbook places intense focus on germline pathogenic variants.
This is a critical nuance. We're primarily looking at BRCA1 and BRCA2. Today, clinicians heavily utilize tumor-only next-generation sequencing. You biopsy the tumor, run the sequence, and it flags a BRCA mutation.
But that test alone does not tell you if the mutation is somatic, meaning it was acquired spontaneously and exists solely within the tumor, or if it is germline, meaning it was inherited and is present in every single cell of the patient's body.
Right, so if a test identifies a mutation in the tumor, the clinician cannot stop there. They absolutely must order follow-up blood or saliva testing to differentiate germline from somatic.
Because if it's germline, it fundamentally alters the patient's entire life. It dictates future screening protocols for secondary cancers, indicates the need for risk-reducing surgeries, and triggers cascade testing for their family members who might unknowingly carry the variant.
And the genomic behavior of these tumors also changes over time, requiring constant vigilance. The textbook highlights the rising use of liquid biopsies, extracting cell-free DNA from a simple blood draw to detect reversion mutations.
This is essentially forced cellular evolution in real time. When a tumor is suppressed by a PRP inhibitor, the evolutionary pressure is immense. In some instances, the tumor biologically mutates its defective BRCA gene back into a functional reading frame.
Wow, it restores its own DNA repair capacity.
Yes, rendering the PRP inhibitor completely useless. Detecting these reversion mutations non-invasively allows clinicians to anticipate drug resistance before a tumor visibly grows on a scan.
The tumor literally learns to fix the generator we just destroyed. It's terrifying, but it is brilliant biology. Now let's pivot to the other crucial patient demographic: age.
This is a tough one.
The text outlines a really stark reality. Despite the fact that cancer disproportionately affects the elderly, there are practically no established evidence-based guidelines tailored for treating elderly gynecological cancer patients. Clinical trials historically just exclude them.
We are largely flying blind. We're taking toxicity and efficacy data from healthy 50-year-olds and extrapolating it to 80-year-olds. And extrapolating that data is inherently dangerous.
Because chronological age is a terrible metric. Biological age is what matters.
Exactly. The absolute priority is distinguishing between a fit elderly patient who can handle standard aggressive therapy and an unfit or vulnerable patient who will suffer life-threatening toxicity. To do this objectively, geriatric oncologists use a comprehensive geriatric assessment, or CGA.
It's sort of like tuning a high-performance engine. You cannot push an older, brittle engine with 100,000 miles on it to the exact same RPM redline as a brand-new engine off the factory floor without risking a catastrophic breakdown.
But you still need that older engine to finish the race. You still have to eradicate the cancer.
Exactly. That analogy perfectly captures the clinical dilemma.
And that's why we rely on tools like the Geriatrics Vulnerability Score, or GVS. It calculates risk by measuring functional independence, looks at biological markers like blood albumin levels, and evaluates underlying anxiety and depression. A poor GVS score flags a patient as highly vulnerable.
But the textbook warns against the instinct to simply undertreat these vulnerable patients out of fear. And the French Gyno trial is a perfect, sobering example of this.
It really is. The Gyneco trial demonstrated exactly why we need hard data, not just compassionate assumptions. Investigators took vulnerable elderly ovarian cancer patients and attempted to de-escalate their chemotherapy.
So instead of the intense standard combination of carboplatin and paclitaxel, they administered single-agent carboplatin.
Right. The assumption was that the gentler treatment would be easier to tolerate and therefore more feasible to complete.
But the strategy completely backfired.
It did. The results were counterintuitive but undeniable. The single-agent arm actually resulted in worse treatment feasibility. Only 48% of patients completed the single-agent regimen compared to 65% on the standard combination therapy.
Wait, really? The gentler one was completed less often?
Yes. Furthermore, their overall survival was significantly worse. By de-escalating the treatment, they failed to control the aggressive disease. And rapid disease progression and tumor growth are ultimately far more physically devastating to a frail patient than the transient toxicities of the chemo drugs.
Wow. You cannot guarantee safety by sacrificing efficacy. It is a razor-thin tightrope. This complexity reinforces why patient-reported outcomes, or PROs, are becoming mandatory endpoints in modern trials.
For the elderly population, extending raw survival by 2 months might not be the primary goal if those 2 months are spent in an intensive care unit. Subjective endpoints, quality of life, maintaining independence, they must be prioritized right alongside objective tumor shrinkage.
The patient's subjective experience has to be the central pillar upon which all these complex genomic decisions are built. Well, We have covered an immense amount of scientific ground today. We are witnessing the definitive end of generic protocols in gynecologic oncology.
We really are.
We've explored how bevacizumab starves tumors, how PRRP inhibitors exploit synthetic lethality, and how immune checkpoint inhibitors are revolutionizing the treatment of MSI-high endometrial cancer.
And we've seen tumors fundamentally reclassified by their molecular drivers and matched to adaptive master protocol trials. It is arguably the most rapid era of discovery in the history of the field.
And as promised to our medical learners, it's time to solidify this knowledge with our review exercise.
All right, here is your clinical scenario based on everything we've covered. A patient with a recurrent endometrial cancer undergoes comprehensive genomic testing. The pathology report indicates her tumor has a high degree of microsatellite instability. She is confirmed MSI-high.
Okay, so based on the biological mechanisms we just discussed, which specific immune signaling pathway should be targeted, and what is an example of an FDA-approved monoclonal antibody designed for this exact scenario?
Think about the mechanism of the tumor's invisibility cloak and its high neoantigen load. The correct answer is targeting the PD-1/PD-L1 pathway. And the standard FDA-approved monoclonal antibody for this scenario is pembrolizumab, or alternatively, dostarlimab.
Excellent. If you understand the why behind that answer, you have a solid grasp on the future of this specialty. As we wrap up this deep dive, we want to leave you with a final paradigm-shifting question to consider as you follow the ongoing research in this field.
As omics technologies continue to advance at blinding speeds, moving from analyzing the bulk tumor down to single-cell profiling and incorporating multi-omics that evaluate the proteome and the metabolome, we have to ask ourselves something radical. Will we eventually reach a point where the traditional anatomical origin of the cancer completely loses its meaning? In the near future, will it even matter if we call it ovarian, cervical, or endometrial cancer? Or will treatment and prognosis be dictated purely by this specific molecular fingerprint, the exact genomic circuitry of that individual tumor, regardless of where in the body it first started growing?